Hello, good morning, everyone. So my name is Thun I. I'm from King Chulalongkorn Memorial Hospital, and this is the last session for this morning. Sorry. So I would like to say that I'm not the expert in the hip osteotomy, but I'm seen some, so I'm gonna share my experience today with the hip osteotomy. But the hardest thing is everyone in this session just talk about everything about the hip dysplasia. So the large option will be the hip osteotomy, which is very difficult. One moment. So I would like to thank you, all of you again for joining us for this early morning. We still have plenty of time because it's still 8:10. So we have 20 minutes left for this session.
For an announcement, after this session, it would be the opening ceremony of the TOSSM meeting. On behalf of the organizing committee, we would like to invite all of you to join the opening ceremony at Hall A and B. After this topic, there would be no Q&A session to let you join the opening ceremony. If you have any question, please ask to the speaker.
Okay. So I'm gonna start anyway. So this is my outline today is about the hip dysplasia. So I'm gonna start with Ajahn Dinan also mentioned about my hip dysplasia. It's very common in the hip specialty. It's more common than the impingement in our region in the Southeast Asia. The estimated to cause the secondary osteoarthritis is about 1/4 to 1/2 of the young adult. So this is like quite more common in our population compared to the Caucasian population. As we know that if the patient have the dysplasia, there's a study in 2005 that if the patient have the center edge angle that mentioned by Dr. Danaithev, if it's less than 25 degrees, the risk of the arthritis is increased by 4.5-fold, 4.3-fold. And each 1 degree that's less than 25 degrees is a 1% increase in the osteoarthritis risk. So that I want you to think about the other thing other than the dysplasia. Sorry. ทำไมแล้วผมอ่านไปอ่ะผมก็ต้องกดนี่ไปอ่ะแล้วผมจะกดสไลด์นี่ไงอ่ะOh, okay. So we shall continue. Okay. So in addition to dysplasia, there are two sides of the coin. You have to think of the abnormal hip version, which can also contribute to the early hip osteoarthritis due to mechanism. The impingement and the instability. If the hip is retroverted, it can lead to posterior instability or the anterior impingement. You have to imagine of the 3D anatomy of the hip. On the other hand, an anteverted hip can cause the anterior instability or the posterior impingement, which both can lead to the early osteoarthritis. So, at the part of the workup, it is crucial to assess the back, the pelvis, and the spinal pathology. This is because abnormal motion in the spine can lower the threshold for hip impingement, which can contribute to pain. By evaluating this area, we can gain a comprehensive understanding of the underlying factor which contributes to hip pathology. So this is also mentioned by Dr. Thawan. During the physical patient history, it's typical for them to report groin pain. However, they may also present with the lateral hip pain. And another common symptom with the presence of the Trendelenburg case. Additionally, a history of minor trauma is frequently reported. Patient may experience pain during hip flexion or external rotation while weight bearing, as well as prolonged discomfort when sitting or standing. The symptom can overlap with those of the femoral-scapular impingement syndrome. So for the examination, I will gonna skip it, but I have the specific test for the hip instability or the dysplasia. So the instability in the hip is different from the instability from the shoulder or on the knee, because the hip instability can cause only pain. The patient will suffer from pain, not just, they don't feel like the hip is coming out, but they feel just pain. So the test for the instability of the hip is to do a maneuver that intend to load the anterior labrum and capsule in an effort to replicate the patient's symptom. The anterior apprehension sign of the hip or the prone instability test. The anterior apprehension sign of the hip we can do by place the femoral head in an unstable position, causing anterior subluxation with associated discomfort or apprehension. And also the same with prone instability test. And we have to also to test for the hyperlaxity with the Bayesian score that mentioned by Dr. Thawan. There's another simple test which is proposed by Professor Ranawat in 2017 that we can do in the outpatient department, which is called the foot progression angle walking test or the FPAL. So we can do this by just simple internal rotating the hip or external rotate the hip while walking. This test involves observing the patient walking pattern with toe in and toe out position. A positive result in external rotation indicated hip instability, while a positive result in internal rotation suggests the impingement. And this is quite useful in the outpatient department. So I'm not going to mention about the X-ray because Ajahn Dinan and Dr. Danaitep also mentioned this a lot. And you have to know that the dysplasia is indicated in the patient with the center edge angle of less than 25 degrees, and the borderline should be 20 to 25 degrees, and the tonus angle is more than 13 degrees. But I have to tell you how do I assess the acetabular retroversion or anteversion. First, you have to assess the quality of the pelvis stream, and you have to assess the posterior wall, which is you have to look for a center of femoral head, which is the lateral or medial to the wall. And also, you have to look, the angle of the posterior wall is very important. If it's quite a straight line, which means this is significant. But if it's just in the curved line, it's still not that bad. And you have to look for anterior wall, the crossover side, which is, you have to think of the small crossover side or the large crossover side. And the last thing you have to look for is ischial spine. So that's why I separate into two categories. The first one is the true retroversion. The other one with the normal socket with anterior over coverage. For the true retroversion, the patient should have the posterior wall medial to the femoral head. They should have the vertical posterior wall, the large crossover side, and the positive ischial spine side. But the other thing is about the normal socket with anterior over coverage. So this one, they will have just like a small crossover side and may not have the ischial spine side. For about the periastular osteotomy, the true retroversion is indicated for the operation. About the MRI and CT also help us find secondary pathology, especially the other things such as the injury of the abductor or the capsular tear or the fracture or the tumor that can be found. Also, we can detect the labrum, which is larger than normal in the dysplasia population. The CT scan also help us evaluate the version of the acetabular and also the femur. So I was taught to think about the combined version, which is quite common for the use in hip arthropathy. The combined version, which is the version of the acetabular and the femur. So if the version is much, which means that they will have more risk of the instability. So if it's more than 60 degrees, you have to think of the instability. But if it's less than 30 degrees, you have to think of the impingement. So this version, the combined version by McKibbin actually is the newborn surgeon, orthopedist newborn surgeon, did the study in newborn population. But everybody used his theory to use also with the total hip replacement and the sport medicine now today. So at this index, the by McKibbin approach the upper lower limit, the more osteoarthritis. So with the recent study in the history about the arthroscopy in the borderline hip dysplasia, it to do only the debridement, did the capsular cut without repair and show the poor result. But currently, recent study have reviewed improved outcome following hip arthroscopy, particularly in case of my dysplasia. The modern approach to arthroscopic procedure includes the label repair, capsular repair application. So the indication is more refined and the result is getting better. But if we talk about the polyarticular osteotomy, in 1983, Lionel Gann, I think everyone know him if you are a hip surgeon or you are orthopedics. He introduced a groundbreaking technique for the polyarticular osteotomy. This technique aims to preserve the posterior column integrity while enabling significant multidirectional correction. Furthermore, it emphasized maintaining the true pelvis shape and preserving the blood supply to the acetabulum. So, other than the traditional PLO, there's another type of osteotomy known as the reverse PLO, which is specifically utilized for addressing the retroverted acetabulum. So, when to do the traditional PLO, the traditional PLO is typically performed in cases of an anterior acetabulum with a low volume or dysplasia. In addition, the cam resection can be done if the patient have a large cam or the large alpha ankle, which is mentioned by Dr. Adinan. What about the reverse PLO? Reverse PLO is indicated in patients with a true retroverted hip and unstable joint. This procedure aims to address the retroversion of the acetabulum and improve the joint stability. The reverse PLO can be combined with cam resection as well. This combined procedure allows for correction for both retroversion and the associated cam deformity. So, what about the combined procedure? Should we perform the osteotomy alone or combine it with the arthroscopy? Combining the procedure can be considered in cases of groin pain that indicated intra-articular pathology and show evidence of labral detachment. Without the labral detachment and the pain locate laterally, so the osteotomy alone should be sufficient. So for my approach, if we face a young person with moderate to severe dysplasia, they have the small to large labrum and mostly the pain on the lateral sides, then the surgical plan should be the scope plus the polyarticular osteotomy. On the other hand, if we face a patient with older population with just only mild hip dysplasia, with labral hypertrophy and good labral tissue, with mainly the pain is at the groin, so the surgical repair of the labrum and the capsular application should be sufficient. So, as I talked to you about the McKibbin, they guided for the treatment of the hip osteotomy, but I've skipped it because we are out of time. And for the last thing, I'm going to talk about the complication which is quite common in the polyarticular osteotomy. The recent systematic review in this year comprised of about 4,260 PLO procedure, and the complication is very high with the major event and the minor event. The major is the the most frequent measure is the event is the peroneal nerve dysfunction and the acetabular necrosis. But the minor event is quite high compared to the total hip arthropathy. So the complication is still high. So this is the last thing about the case. This is the 20 years old soccer player with the pain in the groin and the lateral hip with the mechanical symptom. You can see the left hip is more severe dysplasia. I measured the alpha angle is 40 degrees, which is not indicate of the FAI, but the center edge angle is just 12 degrees. So this patient underwent the hip arthroscopy with capsular repair and the label repair. And after that, they do the periapsal osteotomy. Okay, for the conclusion, so we have to understand the workup of the DDH and the version is very important. So that's a role for the arthroscopic management, but you have to pick the right patient. Osteotomy is a great operation, but you have to beware of the complication. So PAO is the final answer. I don't think so, because you have to think of the other thing as well. So today I want to thank you, my teacher today, Ajahn Somsak and Ajahn Kittipong. And also I have a chance to learn with Professor Anil Ranawat. I want to thank him as well. I want to thank you all of you today that have you with us today. Thank you for your attention.